I'm going to talk about the routine evaluation that we perform on these patients at NIH and the response that we've seen to TNF inhibition, and also give a few suggestions for supportive care. So far we've seen 25 patients at NIH, and each of them has undergone blood work for laboratory assessment and research studies, of course, physical exam with vital signs, brain MRIs, abdominal ultrasounds, and at each visit they're seen by our hepatologists and neurologists, and at least at the first visit by our dermatologists and ophthalmologists. We also tried to document the physical findings with photography. So what we have found is that on many of the patients, but not all, have signs of inflammation with increased CRP and sed rate that have responded dramatically to TNF inhibition. Also, their serum iron, which is a reflection of their chronic inflammation as it is decreased in patients who are chronically inflamed, responds to TNF inhibition. And likewise, their anemia tends to resolve, and we have not seen any patients with red cell aplasia at this time. A number of the patients do have thrombocytopenia, and we have noticed some improvement in that as their splenomegaly is under better control because splenic sequestration appears to be involved, at least partially in that. And a number of them have low white counts, in part because of prior treatments, but not completely. Liver disease is monitored with transaminases, GGT, PT, PTT, and we have noticed a number of patients with hypogammaglobulinemia. In particular, IgM is the most distinctive finding as it's low in these patients. We usually check a quantiferin TB goal prior to starting anti-TNF therapy, as a number of these patients are on high doses of prednisone when they come to see us, and that might interfere with the PPD results. We check autoantibodies at least once, and a number have had low-level ANAs that are positive and positive lupus anticoagulant, but their ANCAs have all been negative. We check urinalyses and have not seen proteinuria suggestive of amyloidosis. This patient is a particularly dramatic example of response to anti-TNF and on etanercept. As you can see, at this point, his CRP had been between 80 and 180, and his sed rate in the 40s. And after he was started on etanercept at the visit where we obtained these labs, his levels normalized rapidly. Other patients have had very similar responses, perhaps not as dramatic, with, as you can see, normalization of CRP and sed rate in those patients who had elevated inflammatory markers, decrease in their white count as inflammation is controlled, and increase in their hemoglobin and hematocrit. When we've documented vital signs, we found that 5 out of 25 had systemic hypertension, and these patients were treated with antihypertensives. 19 out of 25 have histories of recurrent fevers. And on physical exam, almost everybody had livedo on the skin finding, which I will show you. And 18 out of 25 had erythematous nodules, papules, consistent with PAN. 7 had Raynaud's phenomenon, and 6 had significant lymphadenopathy at some time. So another part of the vital signs is monitoring their growth. And this is one patient who, when she first came to us, was on high doses of prednisone and was chronically inflamed and fell off the growth curve. After starting etanercept and being able to be tapered off her dose of prednisone, her height increased at a very steep rate and normalized. These are some of the physical findings that we've noticed in our patients. This extremity photo shows livedo, and also you can appreciate some erythematous nodules consistent with PAN. The second photo demonstrates a particularly marked livedo, and this patient not only had livedo on the legs, which is the most common area, and on the arms, which is also fairly common, but the torso and even his face was affected. This photo here, an X-ray, demonstrate blunting of the third and fourth fingers and also some color changes as this patient had vascular insufficiency and actually had osteolysis of these fingertips. All right, so MRI imaging has shown a particular type of strokes that usually involve the deep brain nuclei and brainstem and they're called lacunar, they involve very small blood vessels. We have one patient who also had spinal cord involvement, and as Dr. Umbrella mentioned, there were 4 patients with hemorrhagic strokes in the past who were all on anticoagulants or antiplatelet medication. One child had a history of a hypertensive crisis and posterior reversible encephalopathy syndrome, and her MRI showed patchy vasogenic edema, but then normalized. All of the MRI imaging and CT angiograms that have been performed on the patients that we have seen have been normal. So before we start anti-TNF therapy, we want to document a baseline MRI, as we have noticed in at least a few patients that they have had subclinical strokes, meaning that nobody knew until we did an MRI and they found evidence of strokes. And if these patients remain asymptomatic, we will repeat the study in 6 to 12 months, although perhaps more 12 months if we need to sedate them. And they are otherwise asymptomatic, as we now know that the anti-TNF therapy has greatly reduced the risk of stroke. These are some examples of acute ischemic brainstem strokes and more chronic deep nuclei strokes. So, let's see. Okay. So another complication of DADA2 is portal hypertension, and this patient came to us and she had had an abdominal ultrasound 5 months earlier that had shown splenomegaly, but it otherwise shown normal flow, hepatopedal flow. So we repeated it because of her very prominent abdomen and also this tortuous vein that was a collateral. And what it showed was splenomegaly and a patent umbilical vein compatible with portal hypertension. So then she underwent EGD, which showed that she had grade 1 esophageal varices. And on a etanercept, we documented that, actually here's the patent umbilical vein that happened in those 5 months between abdominal ultrasounds. But on etanercept, her esophageal varices disappeared, and we recently saw her again, and her massive splenomegaly has decreased, at least in proportion to her size, because her spleen has not increased in size in 3 years on etanercept. All right, but at this point, 3 out of 25 patients have been diagnosed with portal hypertension. 4 patients have had biopsies, and 1 showed nodular regenerative hyperplasia, 2 showed hepatoportal sclerosis, which is an earlier abnormality that can progress to NRH. 50% of the patients we've seen have had hepatomegaly or splenomegaly, and 6 out of 25 have had LFT abnormalities, most of which have improved or normalized on anti-TNF therapy. One of the common sequelae of these brainstem strokes that we've seen are cranial nerve palsies that can cause ptosis, strabismus, diplopia, and anisocoria, and they may require patching so that the child doesn't just use their dominant eye and develop amblyopia. And a few children have had surgery or are planning surgery to help correct the ptosis and the strabismus. As you can see, this child was told to look up, and he is unable to do so with the left eye, and he has a dilated pupil. This child, you can see ptosis demonstration. So a number of other issues to consider in these patients. Some parents are a little surprised once their children are treated, because when they are inflamed and therefore ill, they are sometimes more quiet and subdued, and once they're feeling better, they're a different child, which can cause some behavioral issues. Also, it appears that there are varying degrees of cognitive impairment after stroke, some very obvious and some more subtle, and some of the children have required IEPs. Of course, dealing with a chronic rare disease, many people would benefit from psychological support. And physical therapy and rehab have seen a number of our patients who have had strokes, and one patient underwent serial casting to correct her toe walking, and that was very successful. And you also need to continue to be seen by the internist or pediatrician, as still common things can happen in these patients. Meaning, for example, one patient, although she was much improved, continued to have severe headaches, which were not caused by strokes, as documented by MRI, but she has responded very well to migraine prophylaxis. So regarding treatment, we started by hoping that a fresh frozen plasma infusion could be done periodically and that would help. We performed a small phase 1 trial, but found that it was unfeasible because it would require high volumes in order to get enough ADA2 enzyme, and the half-life of the enzyme was so short that it would require daily dosing. At this point, we discontinue aspirin and anticoagulation in all our patients. And I know someone mentioned the risk of cardiovascular disease and perhaps giving aspirin, but at this time, all the patients that we've seen are under 30 years old, so they're not at high risk for that, but we can reconsider. We treat the patients who have hypogammaglobulinemia with IVIG replacement, and those with high blood pressure with antihypertensives. Our current practice is to begin anti-TNF therapy in all our patients. Although I know Dr. Umbrella mentioned that one patient, well, more than one patient has been reluctant to do so. That was one young adult patient that she mentioned. And we also, we performed genetic testing on all the siblings of our affected patients, and we found one who was affected with DADA2, and her mother believed that she was really asymptomatic, but a review of her laboratory work showed chronic anemia that had been noted early in infancy, low IgM, and then when she developed it, she was only 1 year old, but when she developed a fever, she developed nodules on her legs. These did resolve within a month or so, and eventually, as she got closer to the age where her brother started to get more ill, and he had had a stroke at 4 years of age. The mother was willing to start her also on etanercept. We strongly advise against holding the TNF inhibitor for most illnesses and surgical procedures, because we have been asked, should they stop it for strep throat and that, ear infections, and we say no, because the risk of stroke is too great in our mind. So our usual medication that we start in children is etanercept, and the therapeutic range that we use is 0.8 to 1.2 milligram per kilo, but as we learn more, we've been starting at the higher range, higher dose. We've also been switching more and more commonly to adalimumab, a more potent monoclonal antibody, as a number of our patients have had some breakthrough symptoms, such as persistent PAN lesions. Most of them cleared on etanercept, but not all, and all of them cleared on adalimumab. One patient developed recurrent fevers and lymphadenopathy and responded well to adalimumab. And recently, one person had what appeared to be HSP, and we switched them also. The young adult who I showed you the X-ray and photo of the distal phalanx osteolysis, he was started on golimumab, which is also a monoclonal antibody. So our recommendations are, if on etanercept or adalimumab, you notice that your patient with DADA2 has flares of their symptoms, first check to make sure they are on an appropriate dose. If not, you can increase perhaps the dose or the frequency, and then consider switching to a different TNF inhibitor. Although a number of people do give prednisone, we have noted that a number of the people we follow have had strokes while on prednisone versus TNF inhibition, and which we have not seen any strokes on that. So in conclusion, monitor for complications of DADA2, such as strokes, hypertension, portal hypertension, cytopenias, and hypogammaglobulinemia. And TNF inhibition appears to prevent strokes, slowly reverse portal hypertension, and improve laboratory abnormalities. And a number of consultants' input is required with these complicated patients.